All right, let's go ahead and start grand rounds. Today we have very special grand rounds. This is a grand rounds. It's a memorial lectureship set up to honor one of our Allergy Immunology fellow graduates who passed away, unfortunately, at a young age. His wife had put together what we needed to develop a professorship in his honor and an annual lectureship. And we're very pleased today to have an outstanding guest here to speak in Dr. Reddy's honor. I'm going to turn this over to Dr. Bana, who will make the formal introductions, and we'll get the program underway. So thank you all for being here.
Thank you very much, Dr. Buchini. As Dr. Buchini mentioned, it's a special lectureship in which we remember a special colleague, friend, who served the community very well, and his kind wife, she's also a professor. She established this wonderful lectureship, and we have been doing it for some years. Always we have a special speaker for it, and for today's, the speaker is special in a way that I watched his career growing, and I admired him for more than 20 years. And just it was wonderful to see the people that we watched early as a seed coming out as a wonderful tree with fruit in that. I say a word first about the honoree, Dr. Kamal Reddy, who was a wonderful person around here in Bossier City. He was born in India and obtained medical education there. Then after internship in India, he went to practice in India and Nigeria. And then he moved to the United States, where he got his internal medicine residency in Chicago, and then Allergy Immunology fellowship here at this institution, and he practiced in Bossier City next door. His departure was a great loss, no doubt, not only to his family and many, many friends, but also to the patients, because he treated any person regardless of any payment, regardless of any monetary compensation. And we started this fellowship. I sent a note to several people to ask if he can say a word about Dr. Reddy. So the chairman of the Department of Medicine wrote his responsible, kind, that's at the time when he was a resident, courteous, great desire to help. His moral and ethical standards were of the highest caliber. These words are not easily written by a chairman about a resident. As the associate chief of staff and vice chairman of the Department of Medicine during his residency, also responsible, organized, efficient, very gentle, respectful, compassionate, honest. You can't find more words to be written about a person than that. The director of the specialty medical service wrote excellent clinical judgment, very well liked by his patients, his peers, ancillary personnel, and everyone. The director of acute evaluation unit, hardworking, responsible, his medical records complete and accurate, well liked by patient and staff. And our chairman, who saw Dr. Reddy during his fellowship in allergy here, was pleasant, soft-spoken, and dedicated to learning and to his patients. And the chairman of otolaryngology, Dr. Chirian Nathan, who did not arrive, probably she's in surgery now, described him as a quiet gentleman. His relationship with Sobhaus, his wife, reflected his quiet and intense loving personality that came through not only in his personal relationships, but with patients as well. And the head of cardiology, Dr. Pratap Reddy is not here yet, the kindest man and most compassionate physician that I know. Dr. Kutulingam, professor of pathology in the back here, wrote that he's warm, congenial, friendly, and intelligent person. Dr. Anamandra, a genetist, is not here. An excellent allergist and a very compassionate physician. When indigent patients approach him, he bends over backwards to help them. That was very true about him. In 2009, Dr. Reddy's wife, who she's with us here, kindly came from another state, offered a generous donation to establish this endowed professorship in memory of her husband, whom she said he was grateful for obtaining his allergy immunology training at LSUHSC Shreveport. She also donated to the allergy immunology section several equipments and supplies from Dr. Reddy's office. The school was grateful to receive the donation and matched it with the state money, and the professorship was established in November 2009. Dr. Subha Turu, she is a professor of endocrinology. She was here in Shreveport, was at the school and the VA Medical Center. In 2009, she moved to Albany College of Medicine and recently moved to the VA hospital in North Carolina. We'll come back to the word Albany College of Medicine. She was married to Dr. Reddy for nearly 30 years that she described as the best years of her life. She also considered herself very fortunate to have shared her life with a man who made every single moment they shared very special. The speaker of today completed a triangle here. I knew the speaker, Dr. Celestin, for more than 20 years, independently before my coming here, 13 years ago. And I knew Dr. Sobha from here, and it turned out that they know each other also. So I would like that, Sobha, if you can say a word about your friend, Dr. Celestin, please.
Hi everybody, good morning. It's a great pleasure for me to be here. I came as a junior faculty in this institute and became a full professor, full academic professor at VA, and moved on to Albany because I could not live without my husband here in this town. It is a warm town, very happy life I had. So I moved there, and that's where I know Jocelyn Celestin. Jocelyn is not only a good allergy physician, great allergy physician, very pleasant, very sweet, like a bouquet, as I was telling you yesterday, and good soul. That's what I wanted to say. Rest of the things Dr. Sami Bana will mention, but I'm so happy, though I moved 3 months ago because of brutal winters in Albany. I moved to back to Columbia, South Carolina, where I'm a professor and I'm at VA Medical Center. The same job I'm doing all over. And I know Jocelyn for the last 6 years. Since I moved there, he finishes his allergy clinic, and I will go there to run my endocrine clinic in the same office. So that's how I know each other. We work in the same place. And everybody likes him. I'm glad that he's here to enlighten about whatever topic he chose.
Thank you very much, sir. Dr. Celestin, a very diversified, well-trained, I call him even overtrained, overcooked. He obtained his medical degree from the University of Montemorelos, Mexico, with honors. Then got Master of Science in Physiology in Loma Linda University, followed by residency in Pediatrics at Loma Linda. Became assistant and associate professor of physiology, pharmacology, and pediatrics back to the University of Montemorelos, Mexico. He has a triple fellowship, and not easy to get that. because this triple fellowship, not just in like some people from rheumatology and allergy and pulmonary, we get some of this, but he got all the three in allergy immunology. He started at Hypereosinophilic Medical Center, in the place that I was trained, but about almost 20 years before him. We were trained by the same mentor, Douglas Heiner, if you heard about Heiner syndrome. Then I left from there, various places, and I moved to Florida. And Dr. Celestin desired, he custom-made his training. He asked, can I come for a year from Florida? So of course he was welcomed, and he came and did a wonderful job there. Then I said, can I go to Harvard, Boston Children's more? And he went and spent 2 years there as well. So he's the only one who spent with his own desire 4 years in allergy immunology in very good institutions, diversified, and custom-made his career in his own hands, which is wonderful. He was appointed as assistant professor, then associate professor, and will soon be a professor of medicine and pediatrics, and director of the allergy and the asthma and immunology center in Albany Medical College, where he worked with Dr. Subha there. And he dared to found an allergy immunology fellowship, which is not an easy task, though, but he did it, and soon he will graduate the firstborn next June 30th. Please can send baby gifts for him. He's a fellow of the Academy of Pediatrics, the Academy of Allergy, the College of Allergy, member of several active committees. He was chaired a primary care rotations committee. He was received several awards while he was even in the medical school and afterwards, whether in Mexico or at Loma Linda. And then he obtained the National Research Service Award 3 times and got awards from the Academy of Allergy, Asthma, and Immunology. And he was also a professorship award from the Academy in the name of a past president, Dr. William Pearson, who passed away. I have a message for you, Jocelyn. When I contacted our mentor, Douglas Heiner, told him Jocelyn is coming, he wrote back just 2 days ago, please give my warmest regards to Jocelyn. He has a terrific wife and family and is himself an outstanding doctor. And this I consider as a great compliment for a great mentor. At this age, he cares of us and he's happy to hear. In fact, that he's asked that if you have a handout, I should send it to him to that degree. He likes to receive also any paper that we publish in that, and I see he's genuine in that. So that is, I will give you this slide, Jocelyn, for that. So it's a pleasure to having you, Jocelyn, with us, and please come to start your presentation, which will be on evaluation of peripheral and tissue eosinophilia in children. After the presentation, 9:30, he will talk about the cellular and molecular biology of eosinophils in our section on the 5th floor. Any interested people to come. It is a pleasure to present to you a plaque for this visit.
Thank you.
Jocelyn.
Thank you.
Then come back.
Thank you. Thank you.
Put this on.
Thank you. Good morning. I am overwhelmed this morning. Thank you, Salah. Thank you, Dr. Banner. Thank you, Mr. Chairman, for the invitation to come here and speak about a topic which is very near and dear to my heart, We're talking about eosinophils. Let me just say a word about all the good things that have been said. And I think I can say that here. I am in the South. When good things happen to us, it does not necessarily mean that we are very smart, we are intelligent, but very often it means that the good Lord has placed good people in our path. And those good people such as Dr. Heiner, Dr. Good, Dr. Banner, Dr. Reddy, all of those are very good people that the good Lord has placed on our path that have helped us along. So it's not because we are smarter than anybody else. There are many people that are much more intelligent than us, that have not been able to achieve some of the blessings that we are getting. Just a point that I would like to make. We will talk about eosinophilia, peripheral and tissue eosinophilia in children. And I have no conflict of interest. I don't get any money from drug companies, or I don't have any stock in any company. And what I would like to talk about today is I would like to review with you briefly the basic cellular and molecular biology of eosinophils. I'll talk more about that with the fellows later on. And I would like to review the most common disorders associated with peripheral and tissue eosinophilia, the most common, not all of them, the most common ones. And I would like to talk also about the current and future treatment modalities for eosinophilic disorders. What you see here in the middle of the slide is a picture of an eosinophil, the bilobe, and that cell which stands richly with eosin, that was discovered by Paul Ehrlich in 1879. Why do we have eosinophils? Eosinophils protect us against parasites because they have cytotoxic activities. They can initiate and propagate inflammation. They can modulate both adaptive and innate immunity. And because they have ribonuclease activity through the effect of eosinophilic cationic protein and eosinophilic derived neurotoxin, they can be very effective against viruses. And also eosinophils have the ability to increase smooth muscle tone. So they're pro-inflammatory, they're cytotoxic, they're antiviral, they increase smooth muscle activity, and the last but not the least, they can also present antigens to T cells. And this is work that we have done in Boston about 20 years ago, where we were able to show that antigens can be captured by eosinophils. Eosinophils can express MHC class II, can express some costimulatory molecules such as CD80, CD86, B7, B2, and in the process can present antigen to T cells and get T cells to proliferate and release interleukin-2. Where do eosinophils come from? They come from a progenitor cell in the bone marrow, the CD34 positive progenitor cells. And due to the effect of certain transcription factors, such as GATA1, PU1, and C, EBP, the eosinophilic binding protein, and those transcription factors would help eosinophils in the bone marrow. And then subsequently, you have the effect of interleukin-3, interleukin-5, GM-CSF. All those cytokines are critical in favoring the development of eosinophils. If that comes in your board, and that's the answer, interleukin-5 is the most important cytokine for the maturation, for the activation, and survival of eosinophils, interleukin-5. although interleukin-3 and GM-CSF can also do that. The eosinophils produce and store primary and secondary granules before exiting the bone marrow. And there are a number of chemokines that are important in the migration of eosinophils into the tissues. Perhaps the most important one currently is eotaxin 3. This is a chemokine that we have done work with also in Boston, and we have shown that eotaxin 3 has the ability of attracting eosinophils in sites of inflammation. Rantase is also a very important chemokine that will attract eosinophils and will cause eosinophils to migrate in sites of inflammation. Here's a cartoon that has been put together by Mark Rothenberg, who was at our institution a couple of months ago. And you see the CD34 progenitor cells in the bone marrow and those transcription factors that will cause some development and maturation of the eosinophils. And then with the help of the cytokines, interleukin-3, GM-CSF, and interleukin-5, the eosinophils will acquire the properties of making all those granules. And then the eosinophils will migrate outside of the bone marrow with the help of interleukin-5. And the endothelium and the venules, capillary venules, the eosinophils expressing some beta-2, beta-1 integrins will bind with selectin on the surface of the endothelium. And then there will be that rolling movement and the attachment to the endothelium and then the diapedesis of those cells through the endothelium and stimulated by eotaxin here. And the eosinophils will migrate to some tissues, the stomach, the large bowel, the mammary glands, the thymus, and the uterus. Okay? So normally we have large number of eosinophils in those organs, but as we will speak later on, there should not be in other places such as the esophagus. And when eosinophils are in the esophagus, this is abnormal, and we'll talk about that in a minute. When eosinophils are stimulated, either by tissue injury, infections, infestations, that is, allergens, allografts, and tumor, or if they are engaged due to the expression of those molecules that we're able to show are present on eosinophils, such as MHC class 2, B71, B72, then the eosinophils can get stimulated and can secrete a variety of products, eosinophilic cationic proteins, eosinophilic derived neurotoxin, and major basic proteins, and a whole slew of cytokines that can be released by the eosinophils. And also chemokines, eotaxin, rantase, MIP1 alpha, and a number of lipid mediators, leukotrienes, PAF, and a variety of neuropeptide as well. So eosinophils is a cell which is very dynamic, very powerful, with a lot of properties, and that can do a number of things, not only in the immune system, but in biology of the body as a whole. A couple of years ago, we wrote a paper in which we reviewed the most common disorders associated with eosinophils. And in that paper, we divided the disorders associated with eosinophils into intrinsic, that I would call primary, extrinsic, that I would call secondary, and clonal. But this is a mechanistic type of differentiation. I think it would be more useful to use a clinical differentiation where we think about eosinophilic disorders as caused by allergic diseases, infections or infestations, hematologic and neoplastic diseases, diseases with specific organ involvement, immunological diseases, endocrine, and always leave a section for others. Always leave a section for others. I would like to say a few words about hypereosinophilic syndrome as an indication of an intrinsic or primary eosinophilic disorder. Those patients, although this disorder is not common in pediatrics, much more common in adults, but there have been a few case reports in children as well. Those patients have sustained eosinophilia, more than 1,500 per microliter. In the past, we used to say for more than 6 months, but 6 months is a long time. A lot of things can happen in 6 months. So we prefer to say now that sustained eosinophilia measured more than twice. And usually there is an absence of identifiable etiology, and there is evidence of tissue damage, either the heart, CNS, lungs, or skin. So sustained eosinophilia measured at least twice, absence of identifiable etiology, and evidence of organ damage. Those are the criteria that we use to diagnose hypereosinophilic syndrome. And perhaps the best described intrinsic or primary eosinophilic disorder is, in some patients we have noted that there is an 800 kilobyte deletion in chromosome 4, and then because of that deletion, there is a fusion protein which is formed by the 5' region of the FIP1L1 and 3' PDGFR alpha gene. And we have seen in some patients, not all patients, but in some patients with hypereosinophilic syndrome, there is that fusion protein. And that fusion produces a constitutively active tyrosine kinase, and that tyrosine kinase, constitutively active, drives the production of eosinophils. Fortunately, that tyrosine kinase responds exquisitely to imatinib, that we also call Gleevec. So patients with that fusion protein, that tyrosine kinase that constantly driving the production of eosinophils, respond beautifully to Gleevec or imatinib mesylate. Here is an illustration of what we're talking about. That's a chromosome 4, and over here in Q12 position, there is a deletion, and then the FIP1L1 inserts itself there, and then what you have is that oncogenic fusion that constitutively has tyrosine kinase activity that drives the production of eosinophils. For the fellows and the residents, that's a very favorite questions in boards. Okay, so what are the clinical features of patients with hypereosinophilic syndrome? Usually they're male. We're not quite sure why, and the age range is between 20 and 50, and those patients can have cardiac, CNS, pulmonary, skin, GI, and constitutional symptoms. Constitutional symptoms: fever, night sweat, fatigue, because of the pro-inflammatory activities of eosinophils, and those other symptoms, other problems, can be attributed to the invasion or infiltration of eosinophils in those different tissues. Now, let's talk a little about secondary eosinophilia, parasitic diseases, allergic diseases, malignancy, T-cell lymphoma, and Loeffler syndrome, Church-Strauss, mainly in adults, ABPA, and connective tissue disorders. All those conditions have been associated with eosinophilia. Dermatologic diseases such as dermatitis herpetiformis, inflammatory bowel disease, Eosinophilic esophagitis, we'll talk a little bit more about that. Sarcoidosis, Addison disease, and allograft patients also can develop secondary eosinophilia. Dr. Heiner, this is a paper that I've stumbled upon that was published in the New England Journal of Medicine when Dr. Heiner was a fellow at Harvard in 1956. Okay, Dr. Heiner, who trained Dr. Bana, and I was so fortunate to have him as a mentor, wrote that paper when he was a fellow at Harvard in 1956, describing visceral larva migrans and 3 siblings. It's fascinating and very emotional to read that paper that Dr. Heiner wrote as a fellow at Harvard, 1956. So, those patients, those are usually children who may have pica. They're eating dirt on the floor, and the floor is contaminated with embryonated eggs of Toxacara canis, most likely. And then the egg is transformed into larval form in the gastrointestinal tract, and then get absorbed in the intestine and goes in different areas of the body, and that creates what we call visceral larva migrans. This is a very common cause of profound eosinophilia, particularly in children. The eosinophil count may be up to 80%. 80% of the total white blood count could be eosinophils in children with visceral larva migrans. They have abdominal pain, they have cough, fever, irritability, hives, shortness of breath, wheezing, and those are they can be very sick, although some patients can be totally asymptomatic with that condition. So visceral larva migrans is a secondary cause of profound peripheral eosinophilia in children or adults who may have pica or who may have eaten dirt contaminated with Toxacara organism. And this is a relatively recent paper, and those are the characteristics or the risk factors associated with toxocariasis. They're usually male, less than 18 years old, and this is African American. Pet ownership is very important, and they live in the southern United States. Some of them are foreign born, and whenever you have dogs using public places and sometimes in households, then those are risk factors for toxocariasis. So the evaluation of those patients with hypereosinophilia, including patients with visceral larva migrans, should include a CBC with manual differential. Whenever you have a patient with eosinophilia, please ask your pathologist to review the peripheral blood smear. Okay? Don't count on the machine differential. Ask your pathologist to review the peripheral blood smear. You want to make sure that those cells look fine, they are okay, that you're not dealing with some kind of myelogenic process. And serum tryptase is very important because the activation of eosinophils can cause a stimulation of mast cells that can release serum tryptase. So serum tryptase can be a surrogate of the activation of eosinophils. Look at total serum IgE. That will give you an idea whether or not you're dealing with an allergic kind of situation. Toxocara antibody titers can be measured, but they don't have good sensitivity and specificity. The sensitivity of Toxocara titers measured by ELISA is probably 78%, and the specificity is about 92%. So we still need better ways of of detecting those antibodies. And you can always do Western blot if you're very suspicious. We already talked about that 4q12 mutation associated with that deletion of chromosome 4. So you can detect that either by FISH study. And you may want also, if the eosinophilia is severe and persistent, to do an echo of the heart, make sure that you have infiltration of eosinophils that can lead to heart failure. You may want to do a CT. And at times, you really have to go in the bone marrow and see what's going on there and do cell phenotyping as well. Here is a paper that was published last year in the New England Journal of Medicine. There were 2 sets of paper. And the question that was addressed by those 2 papers last year in the New England Journal of Medicine is whether or not by blocking interleukin-5, which I've told you is the most important cytokine in the survival, activation, and maturation of eosinophils, if you were to block interleukin-5 by generating a specific antibody that will neutralize interleukin-5, can that impact the clinical course of either adults or children with eosinophilic asthma? So that's a very critical question. And that question was addressed by Hector Ortega in that paper that was published in September last year in the New England Journal of Medicine. Okay, so that's what they call the MENSA study. It was a randomized, double-blind, double-dummy study of patients between 12 and 82 years old who have persistent eosinophilic airway inflammation and asthma exacerbation. And those patients, in spite of being treated with inhaled corticosteroids. So they were randomized to receive mepolizumab, that specific interleukin-5 antibody, either IV or sub-Q every 4 weeks for 32 weeks. And the primary outcome was the rate of asthma exacerbation in those patients who have eosinophilic asthma. So that was the protocol. We won't spend too much time talking about it. But here we are looking at what happens. Here, this is the cumulative number of asthma exacerbation, and this is over time. And this is placebo here, and you see that huge difference in patients who have been treated with mepolizumab. Mepolizumab indeed decreases significantly the incidence of exacerbation of asthma in patients who have been treated blocking effectively interleukin-5. Also, you see that there is some improvement in FEV1 as well in those patients who have been treated with mepolizumab. The next paper that was adjacent to that paper, and the same issue of September 25th of the New England Journal of Medicine, deals with the question, if we block effectively interleukin-5, a major cytokine for the activation of eosinophils, what happens with the amount of oral glucocorticoids that those patients would require to control their asthma? In other words, does mepolizumab have glucocorticoid sparing effect? That's what we call the SIRIUS study, and it was a randomized double-blind trial of 135 patients with severe eosinophilic asthma receiving oral glucocorticoids. And those patients were treated with mepolizumab 100 milligrams sub-Q every 4 weeks for 20 weeks. Okay? So the results of that study showed a 50% decrease in the amount of oral glucocorticoids those patients needed to control their asthma. And there was also a 32% reduction in the annualized rate of exacerbation. as shown here. And that cartoon here. Again, you see that's the average dose of oral glucocorticoids. In patients treated with mepolizumab, there was a significant drop here when they were treated blocking effectively interleukin-5. And if you look at the amount or the incidence of asthma exacerbations, you see a significant decrease in patients treated with mepolizumab. And if you do a questionnaire of quality of life, those patients live much better when they were treated with mepolizumab. So blocking interleukin-5, in other words, abrogating the effect of eosinophils, and that subset of patients who have eosinophilic asthma with mepolizumab, you can decrease the incidence of asthma exacerbation. You can spare them from oral glucocorticoids and their terrible side effects. And you can also improve the quality of life of those patients. Okay, so there are a number of treatment modalities beside mepolizumab that has been recently authorized by the FDA under the name of Nucala. We still use glucocorticoids in some patients, and the mechanism of action of glucocorticoids is the suppression of the transcription of eosinophilic cytokines and chemokines. I'll talk more about that with the fellow later on. Interferon alpha inhibits the degranulation and function of eosinophils. Hydroxyurea and vincristine are myelosuppressive. And 5-lipoxygenase inhibitors can block eosinophil chemotaxis through leukotrienes. Chromoline and endochromal can inhibit effector functions of eosinophils, and we already talked about mepolizumab. And Mark Rothenberg in Cincinnati is working on eotaxin, blocking eotaxin, and blocking also interleukin-13 that seems to have effects reminiscent of interleukin-5. Let's talk a little bit about eosinophilic esophagitis, which is a relatively new entity. It is possible that eosinophilic esophagitis has been there for a long, long, long time. We did not know about it, and we treated a number of patients as GERD or etc. But those patients may have had eosinophilic esophagitis all along. So those patients are usually young males with dysphagia. They have trouble swallowing. And in adults, they can even have up to impaction, leading them to the emergency room. In small kids, they have feeding difficulties, and therefore they have failure to thrive. And those patients, if you look at the esophagus, you also endoscopic rings, and you will also see eosinophilia in the submucosa of the esophagus and multiple areas, multi-sites. And they have usually over 15 eosinophils per high power field, and those patients are usually atopic. Here is a paper that also came recently in the New England Journal of Medicine looking at the pathophysiology of eosinophilic esophagitis. There are a number of genetic abnormalities that have been described. For instance, there could be mutation in the eotaxin 3 gene. There could be mutation in calpain 14, TGF-beta1, filagrine, which is a molecule that has been described as critical in patients with atopic dermatitis, the filagrine gene. TSLP, the thymic stromal lymphopoietin, also mutation in that gene can be a factor, and desmoglein. All those molecules are being studied intensively particularly in the lab of Mark Rothenberg in Cincinnati, to see what role they play in predisposing patients to eosinophilic esophagitis. So there are a number of genetic abnormalities, plus sensitivity to food antigens, allergens, and that combination in the rat milieu, microbiome milieu, all of those factors together may be contributing to the generation of eosinophilic esophagitis. Added to that is the decrease in barrier function of the esophagus, okay, causing antigens to penetrate and to cause trouble, such as attracting eosinophils. Also, as we said before, because eosinophils, those factors can also stimulate dendritic cells to present antigen to Th2 lymphocytes, okay, and there could be recruitment, production of cytokines, and attraction of eosinophils, stimulation, production of eosinophils, and then those eosinophils migrate into the mucosa of the esophagus, and in there they cause furrows, they cause exudates, concentric rings, and if that persists for an extended period of time or not diagnosed or been treated as something else, then that can become fibrotic, and that would be a tragedy, children. So there are a number of factors involved in the generation of eosinophilic esophagitis and causing eosinophils to migrate from the blood into the esophagus, causing significant damage here and with the potential of leading to fibrosis. Here you see some eosinophils here with the arrows shown. If you have more than 15 per high power field, that's one of the criteria to diagnose eosinophilic esophagitis. So is eosinophilic esophagitis an atopic disease? Well, perhaps. About 2/3 of those patients have atopy, and seasonal variation in symptoms and levels of eosinophils in the esophagus has been demonstrated. There is an increase in Th2 cytokines, such as interleukin-5, interleukin-13, upon stimulation of T cells with allergens. Okay? And in the mouse, Mark has been able to show that you can sensitize mice and get them to develop a form of eosinophilic esophagitis. And also by data that has been generated in Spain by Lucendo and others, allergen avoidance can restore normal esophagus pathology. So all those factors would suggest that eosinophilic esophagitis could be an atopic disease. Here is data generated again in Cincinnati children. And what you're looking at here is a heat map. Okay, so there are a number of genes here. Okay, some of them are overexpressed in red, and some of them are underexpressed in blue. And you see there is a specific genetic or molecular signature for eosinophilic esophagitis. You see in the normal patient, all those genes here are overexpressed, and all those genes there are underexpressed in normal patients. Okay? Patients with GERD, okay, they have a picture which is very similar to normal patients when you look at all those genes. And patients with eosinophilic esophagitis, all the genes at the bottom are overexpressed, and those genes on the top are underexpressed. And patients who have PPI responsive esophageal eosinophilia, and those patients, they have also a pattern that looks like eosinophilic esophagitis. And see what happens when you treat those patients. You change the pattern to something that looks more like normal or to GERD, meaning that you can actually change the molecular signature of that disease by treating patients with PPI. So fascinating. Okay, so this is a paper that was published recently in Mediterranean Journal of Gastroenterology, and they propose that kind of approach in treating children and adolescents with eosinophilic esophagitis. Is the patient treated with PPI? No. Then you have to do biopsy, and if you have more than 15 eosinophils per eye per field, give them a trial of PPI for 8 weeks, monitor the symptoms, and we biopsy them and see how they do. If they have more than 15 eosinophils per eye per field, they have eosinophilic esophagitis. If they have less than 15 eosinophils per eye per field, then they can have GERD or PPI responsive esophageal eosinophilia or other diagnosis. If you have a confirmed diagnosis of EoE, then you have to discuss your therapeutic options. It could be diet, and an empiric elimination of an allergenic diet has been shown to be very helpful. Or you can do a targeted elimination diet based on skin testing. In most recent studies, it doesn't seem to make any difference whether or not those patients are skin test positive to those foods, or you just blindly, empirically eliminate the foods that are known to be allergenic in those patients. And that data came from Spain by Lucendo group. And children, if you give them an amino acid formula, you can completely resolve their eosinophilic esophagitis by giving them an elemental formula. They can also be treated with steroids. This is off-label, but we make them swallow inhaled steroids. You monitor the symptoms, you repeat the biopsy, and see how they're doing. If they don't resolve, then you think about adherence, you adapt the treatment, and if they resolve, you continue to monitor them and try to determine what is the minimal amount of drug that I can give those kids to keep the eosinophilia under control in the esophagus. So, currently we're using antacid, PPI, dietary, avoidance of aero and food allergens. We have them swallow inhaled corticosteroids. And sometimes we have to do bouginage, particularly if they have fibrosis, but be careful avoiding perforation. And then interleukin-5 experimentally has been helpful, but it has not been approved to be used in that entity there yet. But we know this is coming because the data seems to be very, very encouraging. In the future, you will see anti-eotaxin 3, and you will see also anti-interleukin 13 that will be used to treat those patients. And this is a summary of what we just said. Elemental diet, very effective in children. Elimination diet, you can do a 6-food elimination, avoiding milk, wheat, eggs, soy, seafood, and nuts. Or there are people who are using 4-food elimination, and those 2 diets have been shown to be very effective. Okay? Some people can base the elimination diet on skin testing or RAS testing, but that doesn't seem to make a huge difference then compared to eliminating empirically the allergenic food. You can use omeprazole in children, okay, adjusting the dosage. You can also use inhaled, swallowed corticosteroids. And I would like to finish with this paper that just came out in the New England Journal of Medicine. It's time? A minute, okay. Okay, so many things to say. This paper just came out in the New England Journal of Medicine and November 5th issue, and I invite you to go and review that issue. This is something that made a little bit of buzz in the scientific community. This is an HIV patient who did not take his medications and who developed an infestation with Hymenolopis nana, a tapeworm. Okay, so this patient developed an invasive form of Hymenolopis nana, okay, and had significant inflammation. You see all those nodes in the lungs. Those are cervical nodes. And then if you look very carefully here, what you will see is that there are some small cells. And when you look at those cells, you see that they have features that would suggest malignant transformation. Okay? Malignant transformation. The Hymenolopis nana was transformed into a cancer into the patient with HIV. Okay, that has never been reported before. That a tapeworm becoming malignant in a human host. Okay, so that paper obviously made a lot of buzz because that also is another mechanism of malignancy that has not been described before. Now, the problem with that paper, and we know that Hymenolopis nana is a major cause of severe eosinophilia. The word eosinophilia was never mentioned in that paper, not even once. Okay? So one of my fellows, as we speak, is writing a letter to the editor of New England Journal of Medicine. Okay? Because the theory behind the malignant transformation of that Hymenolopis nana in that patient was that because there was no T cells, there was no CD4 cells, and that predisposed the patient to that disease. But it could be, since it was not mentioned, that this patient did not have an eosinophilic response to that infestation, and that may have predisposed that tapeworm to become malignant. Okay, that's an alternative theory that we have, and a letter has been sent to the editor of that paper. It has been a pleasure talking to you. I don't know if we have time for some questions, but I'll be here to answer some of your questions.
Thanks a lot, Jocelyn. It's a wonderful, wonderful talk. I'm very, very proud with your development and your career. Great. Since nobody outside, we may have one or two questions. Yes, Dr. Vancheri. Yeah.
So you mentioned the use of imatinib in the Hypereosinophilic Syndrome. And I wonder what's known about the tyrosine kinase, able tyrosine kinases in particular, in the pathogenesis of secondary eosinophilic disease, and is that a potential place to treat bronchopulmonary aspergillosis and other things in our patients?
Yes, a very, very good question. BCL-ABL has been shown also to be a cause of Hypereosinophilic syndrome, but the best described is that 4Q12 mutation that we talked about, and that seems to respond exquisitely to imatinib. Imatinib may be helpful also in other form of eosinophilia and myelogenic type of eosinophilia, but we are not using it. It has not been shown to be helpful in secondary eosinophilia, so that eosinophilia caused by either asthma or parasitic disease, collagen disease, Church-Strauss, etc. So we don't know whether or not imatinib works, and all likelihood doesn't work in those entities.
Along the same lines, you mentioned the alpha integrins and their importance in the migration of eosinophils into tissue. Other auto-inflammatory diseases are blocking that part of the pathway.
Yes.
Any utility yet or demonstration of?
That has been shown in the lab, but nothing that we know clinically being tested right now blocking the integrins and the eosinophils, or blocking the selectin on the endothelium to prevent the migration of eosinophils into the tissues and causing trouble. But we have data about, at least in the lab, for chemokines such as eotaxin 3. And we have data also for M1P1 alpha as well.
Wait, last kind of question. Mepolizumab in bronchopulmonary aspergillosis.
Theoretically, it could be used, but that we're still using steroids in those patients, as suggested by Greenberger from Northwestern. It is possible to conceive that could be used, but there is no clinical trial that I know of which has been done for that.
Dr. Rice.
Two quickie questions. Do you have any insight on eosinophilic esophagitis? Why is it that usually only the esophageal squamous epithelium is involved and nowhere else in the body?
Exactly. Yeah. A very important question. We don't know. We know that in those tissues there's a lot of TGF-beta 1. Okay. We know there are a lot of mast cells that are accumulating there. Why that homing of eosinophils into the esophagus, we don't know. And search is underway to find that homing molecule that will attract and keep eosinophils in that specific area of the body.
Another is a more practical one. You indicated that when you've got an eosinophilic esophagus, you can treat them with PPIs and other things, and always checking 4 to 8 weeks with another endoscopy. Is this important clinically, or is this more important if you're in a research study of these patients? I mean, the point is that I'm not sure how often I could tackle the patients to get more than 2 or 3 endoscopies.
Yeah, I know. It's a problem. Obviously, we treat patients differently in an academic setting versus in private practice. But what has been done now in the area of eosinophilic esophagitis is to try to determine whether or not we can have some markers, particularly in the blood, that would indicate that disease. And some progress has been made. For instance, there are a number of microRNA that have been shown to be elevated in patients with eosinophilic esophagitis. So there is a potential that eventually we'll be able to look at the microRNA expression of a patient and know for sure whether or not we're dealing with eosinophilia, rather than going and doing those endoscopies that can be very invasive and traumatic.
Yeah, I guess the related question is, because compliance is always a problem. If once you've treated them, they're doing better and they're not having any symptoms, how important is
Leave them alone.
right enough that
Leave them alone, yes.
Right. Last comment, Dr. Bocchini.
Yeah, I just want to, unfortunately, we've run out of time, and so we have to end. But first, I want to thank Dr. Couture for making this possible and making it possible for us to stay connected the way we have, and in the memory of her husband, and bringing the opportunity for us to bring special guests like this here to not only honor his memory, but to help educate us and keep our program strong. So thank you very much.